Okay, we are going to discuss about extracorporeal membrane oxygenation (ECMO). It is a technique of providing prolonged cardiac and respiratory support to person whose heart and lung are unable to provide an adequate amount of gas exchange or perfusion to sustain life. In this video, we will cover types of ECMO, their indications and contraindications, difference between ECMO and CPB, and also we will discuss what are the factors are considered before putting patient on ECMO. We will start with the types of ECMO. There are mainly two types of ECMO, veno-venous ECMO and veno-arterial ECMO. First, we will discuss in detail about veno-venous ECMO. VV ECMO provides respiratory support to the patient with a respiratory dysfunction. Here, deoxygenated blood actively collected through a drainage cannula from a point in the IVC. Then blood passes through oxygenator where carbon dioxide is removed and oxygen is added. Then this oxygenated blood pumped back into venous circulation. Venous cannulas are usually placed in the femoral vein for drainage and internal jugular vein for reinfusion. The tip of drainage cannula should be maintaining near the junction of inferior vena cava and right atrium. Alternatively, a double lumen cannula is available. It is inserted into the right internal jugular vein, draining blood from SVC and IVC and returning it to the right atrium. So when we use this VV ECMO, we initiate VV ECMO when conventional mechanical ventilation fails. The primary indication is refractory hypoxemia, defined as a PaO2 divided by FiO2 ratio of less than 80 despite optimal ventilator settings, or severe hypercarbia with arterial PS less than 7.20. Some are clinical scenarios are: first is acute respiratory distress syndrome (ARDS) from cause like severe pneumonia, sepsis, or trauma. Second indication is bridge to lung transplant. Third is massive pulmonary embolism with hemodynamic stability but with severe hypoxemia. Okay, now contraindications for VV ECMO. The decision to initiate ECMO is a balance of potential benefits versus risk. Absolute contraindications includes irreversible neurological injury, severe irreversible multiple organ failure, patient with severe bleeding disorder, and chronic end-stage lung disease with no transplant option. Now we discuss about veno-arterial ECMO. VA ECMO provides both respiratory and cardiac support to the patient. Here, deoxygenated blood being actively drained through a drainage cannula from venous circulation and passes through oxygenator, where CO2 is removed and oxygen is added. Then this oxygenated blood pumped back into arterial circulation through reinfusion cannula. For a VA ECMO, venous cannulas are usually placed in the right common femoral vein for drainage, and arterial cannula is placed into femoral artery for infusion. If femoral vessels are unsuitable for cannulation, in such a case, the internal jugular vein can be used for drainage and axillary artery for reinfusion. After surgery, patient is unable to wean from bypass. In such a case, to give rest to the heart and to support heart recovery, patient can be transferred on ECMO. The cannulas implied for CPB can be transferred from a heart-lung machine to ECMO circuit. Here, blood drained from right atrium or SVC and IVC and reinfused into ascending aorta. Indications for veno-arterial ECMO. First is cardiogenic shock. It is a condition where heart doesn't pump enough blood to meet body's needs. This can occur due to many reasons like acute myocardial infarction, toxic myocarditis, cardiomyopathies, and post-cardiotomy shock. In such a case, VA ECMO can be helpful. Second is cardiac arrest. VA ECMO is used as a part of eCPR when conventional CPR is not effective. After the arrest, if there is no return of spontaneous circulation within the 10 to 20 minutes, then there is an excess of eCPR to save the patient. Third indication is bridge to transplant. Patient can be put on ECMO until he or she gets heart from donor. Fourth is massive pulmonary embolism with right heart failure and with hemodynamic instability. Now contraindications for VA ECMO. There is no absolute contraindications, but there are some factors which are considered before putting patient on ECMO. First is irreversible multi-organ failure. Second is severe neurological injury. Third is coagulopathy patients. Fourth is if patient is too old. Fifth is patient with aortic dissection and aortic regurgitation. In such patient, VA ECMO is contraindicated. Now we will briefly discuss about what is the difference between CPB and ECMO. First, the purpose of ECMO is it is primarily used to support the patients with severe respiratory and cardiac failure, and the purpose of CPB is it is used during cardiac surgeries to temporarily take over the function of the heart and lung. In ECMO, centrifugal pump is used, and the oxygenators are used in ECMO are designed for longer duration with mostly polymethyl pentane membrane material, which are costly than the CPB oxygenators. In ECMO, reservoirs are may not used. ECMO needs less priming volume and circuit components than CPB, and on ECMO, ACT is maintained around 180 to 200 seconds. Now in CPB uses roller pumps and polypropylene membrane oxygenators are used, which have less duration. It needs more priming volume and circuit components than the ECMO. Here reservoir is used and ACT is maintained above 480 seconds. Okay, now what are the factors are considered before putting patient on ECMO? First is severity of respiratory or cardiac failure. If the patient is not responding to the maximal medical therapy, including mechanical ventilation, inotropic medications and vasopressors, then the patient can be put on ECMO. Second is reversible cause of organ failure. Because ECMO is not permanent or long-term treatment, it is initiated for bridge to patient recovery. Third is if the patient or their family refuse to ECMO support, then it should not be initiated.